All right, thanks for the introduction, Abe. I'll go ahead with my, I have no disclosures related to this presentation. As some of this panel members has mentioned, these are the measures of testosterone. I'll give you a little bit of introduction, so because you have different level of audience here. So in general, normal is considered, like FDA is 300 to 1,000 nanogram per DL being a normal level. It is also important to know, because it's related to my presentation as well, there is directional variation of testosterone. So it has to be early morning testosterone level draw. It's important, and it has to be two separate lab draw to decide if that patient has a low testosterone level. And as all the panel member before me mentioned, 30% will have mildly hypogonadal range, but 15% of healthy will also have low testosterone. A substantial number between 65 to 80 will have low testosterone level, and in the afternoon. So it is a single low level does not mean hypogonadism. You have to have two separate levels. That's being said, definitions already been told by others, so I'll not repeat. This is cardiovascular effect of testosterone. When I got involved, like everybody else who has spoken before me, there is biases when we get, at least when I was training, we are told testosterones are bad actors in terms of cardiovascular health specifically. And I also carried that biases until I did my own research. In general, if this is effect on cardiovascular system, it's a normal testosterone effect on cardiovascular system. I'll minimize the medical jargon here. That means it increases the coronary and peripheral blood flow. It increases output. Some of the inflammatory markers, we don't have very strong data on that. And conduction tissue, especially, it can stabilize this antiarrhythmic effect of in our heart. Lipid on lipid, I know some of our colleagues already have said some beneficial effect, but also it reduces reperfusion injury. That means if you have a heart attack and you had another, when we open up the vessel, that injury related to that opening up is reduced. These are collected mainly from basic science studies. The biggest impact, I guess, or things get highlighted that it can increase blood clots, at least in the coronary artery thrombus formation. To be honest, that is mainly drawn from what we call ex vivo study. That means outside patients study. Patients were given testosterone, the lab was drawn, and the platelet activity was measured outside with stimulation. So this gets highlighted, and that is the reason for most of the biases related to testosterone. Next is what is the data behind low testosterone and mortality? That means if you have low level of testosterone and mortality, there's tons of studies that I've listed here. In general, most of them show that there is also a decrease in increase in all-cause mortality if you have low testosterone, and there is also increase in cardiovascular mortality. So how I got involved? It's basically when a patient asked me, when FDA gave a black box warning about testosterone replacement therapy. And the patient asked me, doc, I have this and I'm on testosterone, what do I do? So then I started looking at the evidence. I had my biases, or like any other cardiologist or most of the doctor, that testosterone is a bad actor, and we male have higher events because of we have testosterone or higher level of testosterone. First studies that prompted this FDA black box warning is Tom trial. It's basically 209 men over 65. Remember, this was just patients. They were looking at patients' strength, muscle strength, not looking for cardiovascular events. They were not powered for cardiovascular events, and there was a poor randomization. And treatment group also had a higher risk. So in this trial, they suggested maybe patient had more MI, one death, one CVA, one coronary syndrome, or CHF. So that's got highlighted in the media. Next, it was actually a VA study. This is the one who prompted me to really look into my study, subsequent study from this. This is a VA veteran patients who is coming from coronary angiography. That means these people were at least, high risk patients who are having some concern or symptoms. They're coming to the cath lab. From that database, this study was done, and Wagon and et al. Concluded that patients have higher adverse events with testosterone therapy, MI, stroke, or death. But I also, when we look, more closely, the testosterone treatment was inadequate in that population. Then their average level was, 332 nanogram per liter. It's only 60% of them had repeated measure to see if they were actually getting the appropriate treatment or appropriate level were reached. So there, again, subsequently, there's another paper from PLOS. This is also a database study, and no measurement of testosterone was done. In this case, it's just database research. And they suggested there may be an increased fatal MI with testosterone prescription. And after all the studies came out, FDA issued drug safety alert related to TRT, and saying that it increased risk of heart attack, stroke associated with testosterone use. So that's how I got involved. There were a couple of issues looking at these studies. First thing, whether levels were drawn properly. Two separate occasions, at least two measurements showing that they're really hypogonadal. Second issue was, when you're treated, have you treated them adequately? If you haven't treated between 300 to 1,000 nanogram per DL, that is not an effective therapy. So we looked at our VA database, all comers. There's 200 plus VA medical center in this continental US. We looked all of the patients who were getting testosterone therapies and who first got testosterone measurement, who at least had two measurements of testosterone. Then we divided it into three groups. One, they did not receive any testosterone, although they were lower after two measurements. One, they got treatment, but did not go to the normal level. And another group was level 2 level drawn, decreased testosterone, and they were adequately treated. I think our study was a more comprehensive look at the normalization of testosterone. This group of populations did not have any previous MI, stroke in this population, because we wanted to see patient with general risk, not a high cardiac risk. So on that population, we found, to my surprise, actually, I went with a bias, although I had these doubts that that testosterone therapy may be more harmful than good. To my surprise, we actually really propensity matched them. It's a rigorous statistical exercise we have done to make sure we got this right. We found, to my surprise, that patients without previous MI and stroke, if you normalize testosterone, it decreased MI, stroke, and all-cause mortality. And it is also highlighted that if you didn't normalize, you still had a higher event. So normalization of testosterone, what you're hearing, this is really highlighted by our group, that if you treat them effectively, you will have an all-cause mortality decrease, you will have MI decrease, as well as stroke decrease. This is 83,000 patients over 15 years of follow-up. Median follow-up is about 5+ years. So next, in addition to my expertise on the testosterone cardiovascular disease, I also share, actually, other hat is I'm an expert in smoking and cardiovascular disease. So as I showed to you, the most worry for our cardiovascular events coming from increased clot or thrombosis. So we clearly know smoking caused that. And if testosterone is caused also increased thrombosis, in my mind, the smokers should, have more higher events if you give them, higher level of testosterone. So we looked at specific smoking population and compared them smokers and non-smokers as well. And we found that smokers also actually benefited all-cause mortality. Obviously, they were less effective, significantly lower than non-smokers. And there is no increased MI in this smokers group. And they did not obviously benefit from the MI because smoking cause itself, it's an increased risk. So we concluded active cigarette smoking that negates some of the protective of testosterone normalization related to mortality and MI. So what others people have published after that? There was a double-blinded placebo-controlled trial, 2017 by Budroff. They looked at basically placebo versus testosterone therapy. This is a gel form. They compared significant increase in non-calcified plug volume. Calcification and plug volume increase not, I have to say, that not equates to increased event. They were not looking at hard endpoints. Next was a Chetam et al.'s JAMA, is basically a retrospective study. Again, this is found that they're associated lower risk of CV outcome. Next, because we went on, keep on doing more database research on that. Remember, our study was patients without previous MI and risk. We know with previous MI and cardiovascular event, specifically MI, you have a higher risk, like 40% risk of recurrent MI. So we wanted to explore that population as well. This is a smaller number because we were rigorous, trying to be as rigorous as possible in our previous study too. Even in these populations, we found testosterone risk, treatment was associated with decreased or normalization, all-cause mortality. However, recurrent MI benefit was not seen because this is a different population. We did not see higher events.
Rajat, I'm sorry, we're running late. If you could try and wrap up shortly.
Sure. Next slides, we looked at DVT, PE. So there was no difference. This is a slide, we looked at atrial fibrillation, same separate group. We found atrial fibrillation events were decreased as well with normalization. Then this is the last slide. Remember, most of my studies were retrospective and observational. This is a meta-analysis of 35 placebo-controlled trial recently published. They found with a 9.5-month duration, no significant increase of cardiovascular events, and there's no particular subgroup identified has significant increased CV risk with testosterone risk therapy. So in conclusion, low testosterone associated with increased mortality or CV events. In patients with prior MI, without prior MI and stroke, normalization is associated with decreased mortality, MI, and risk. Smoking decreases some of this beneficial effect. Even in previous MI, patients with normalization of low testosterone associated decreased mortality and not associated with higher event. So thank you.